Good afternoon, everyone. Thank you for joining us today for the webinar. We will get started in 2 minutes. Good afternoon again for those who are joining us from coast to coast to coast and wishing your hellos in the chat box. So we will get started in just one more minute and allowing more attendees to join. Hello and welcome everyone to the Mental Health Commission of Canada's webinar on suicide risk assessment. My name is Nitika Rawari and I'm the director in the area of prevention and promotion initiatives at the Mental Health Commission of Canada. Our department works heavily in the area of suicide prevention and life promotion, and we have the utmost pleasure of working with stakeholders from across Canada in this important subject. Before we begin today's webinar, I would like to share that we have received news that some of our attendees today are processing the very recent loss of their colleague to suicide. We would like to acknowledge that most of you joining us today have a personal or professional connection to suicide and the work of suicide prevention as well. When we hear the tragic news of a loss of a friend, a family member, a colleague, or loved one to suicide, we are reminded of how important the work of life promotion and suicide prevention really is. And if anyone is in need of support during or after the webinar today, we are able to offer you some distance support through Mental Health First Aid. We will provide more details around that shortly in the chat box. Also, in the spirit of reconciliation, I would like to begin by acknowledging the Indigenous peoples of all the lands that we are on today. While we're meeting on a virtual platform from every region in Canada, it is important to take a moment to acknowledge the importance of the land which we call home. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nation people that comprise this land in which we live. We're grateful for the opportunity to live, work, and play here, and we thank all of the generations of people over many centuries who have taken care of this land and recognize and deeply appreciate their historic and present connection to this place. I would also like to take a moment to acknowledge that tomorrow, September 30th, will mark the inaugural National Day for Truth and Reconciliation, a day we have traditionally observed as Orange Shirt Day. The uncovering of unmarked graves at former residential schools is a tragic reminder of the deliberate assimilationist policies that removed Indigenous children from their families. To acknowledge the National Day for Truth and Reconciliation, we ask you that to consider researching the Indigenous history of your region, listening to music by Indigenous artists, or wearing an orange shirt to honor survivors of residential schools and those who never made it home. We're pleased to be offering this webinar in both official languages to you today. Today's webinar will be presented in English with simultaneous French interpretation. You'll be able to connect to the French audio by clicking on the interpretation button at the bottom of your screen and selecting French as your language. If you're having technical difficulties, please write in the chat and we will be able to do our best to assist you. If you would like to follow along the slides in French, please select the view speaker. The slider between the speaker's camera and the English slides can be adjusted and moved to the left in order to better view the French slides. Please feel free to ask your questions in the language of your choice at any time in the chat. You can do so by clicking the Q&A button at the bottom of your screen or using the chat box. Questions will be answered during the question and answer period at the end of the presentation today. For ease of reference, please indicate which speaker your question is directed to, or if your question applies to all the speakers today. Finally, considering the topic of our presentation today, I invite you to take note of the distress line number for your region or the mental health first aid contact, Samantha Fota. Samantha Fota is available by email and can support in both English and in French. She will be available to support for the duration of the webinar until about 3:30 p.m. Eastern Standard Time. We will put some additional information in the chat box related to this. Please do not also hesitate to reach out to your local crisis center or distress line for support if you feel that you need it today. Earlier this year, the Mental Health Commission of Canada, in partnership with the Canadian Patient Safety Institution, now Healthcare Excellence Canada, released a suicide risk assessment toolkit. This toolkit provides a high-level overview of what to consider when using suicide risk assessment tools and a non-exhaustive list of available tools and their characteristics. The toolkit was designed to be a quick and informative guide for those interested in selecting and comparing risk assessment tools. We acknowledge that the process of assessing suicide risk is incredibly complex, and there are a number of important considerations that must be kept in mind when doing so. To continue this important discussion on the assessment of suicide risk, we have invited 3 speakers today to discuss a clinical approach to risk assessment, conditions that bring about suicide risk, strengths and challenges in risk assessment with diverse communities, and recommendations for future work. Without further ado, I would love to introduce you to our 3 speakers today. Today, we have the absolute pleasure of hearing from 3 experts whose work relates to suicide risk assessment. First, we will hear from Dr. David Klonsky. Dr. Klonsky is a professor of psychology at the University of British Columbia, a registered psychologist, and an expert on suicide and self-injury. He has more than 100 publications to his credit on suicide, self-injury, and related topics. And in 2015, he co-authored the 3-step theory suicide framework. Next, we have Dr. Allison Crawford. Dr. Crawford is an associate professor in the Department of Psychiatry and in the Dalai Lama School of Public Health at the University of Toronto. She's also a psychiatrist and clinician scientist at the Center for Addiction and Mental Health, where she is the Chief Medical Officer of the Canada Suicide Prevention Service and the Director of Virtual Care. Dr. Crawford has worked extensively with circumpolar communities in the area of suicide prevention and with the Arctic Council. And finally, we have Dr. Joseph Sadek with us, an associate professor of psychiatry at the Dalhousie University and clinical and academic leader in acute care at the Nova Scotia Hospital. Dr. Sadek led the Nova Scotia Suicide Prevention Task Force from 2016 to 2018 and currently chairs the Canadian Psychiatric Association Education Committee. He has also developed a widely used, concise guide for clinicians on assessing and managing suicide risk. So welcome to all our esteemed panelists today. Our webinar today will begin with a presentation from Dr. Klonsky. Over to you, Dr. Klonsky.
Thank you so much. I will get that screen share up. Let's see if we can do this efficiently. All right, please let me know if it's not working. As far as I can tell, the correct screen is being shared right now. So thank you so much. Yeah, it is confirmed. Okay. Thank you so much for having me today. I really appreciate the opportunity. I appreciate all of you in the audience sharing your time with us today. I also wanted to thank in particular Megan, who was the person who's exchanged about 70 emails with us in recent months organizing this. My topic is understanding suicide risk. And the idea is that if we can understand suicide risk, have a practical, actionable, clinically applicable, sensible explanation of what brings about suicide risk, then we can use that information to inform how we can best assess suicide risk across the diverse context, clinical context, applied context that all of you deal with and across diverse individuals. Now, given time constraints, I will focus on the key points, and I will be omitting a lot of substance, a lot of context, and a lot of evidence underlying my points, but there's always opportunities in question and answer and beyond if people want to connect over some of that information. All right, so let's jump in. What I'm going to explain today in my short time is that I think we can efficiently and accurately understand suicide risk in terms of 4 factors, that we can understand the conditions that bring about suicide risk in a fairly efficient way. And the point I will be making is that if we understand someone's pain, if we understand their hopelessness about things getting better, if we understand their connectedness and the extent to which they not only have valued connections available to them, but are able to engage with them, and if we understand their capability for attempting suicide, in that moment at least, we know what we need to know about that person's suicide risk. So I will walk us through this, give some rationale and explanations of what I actually mean by this, and then spend the second half of my time talking about how we use that information to understand risk and to approach risk assessment. So starting with pain and with hopelessness. Sorry, technical difficulties with the Zoom features covering up my window. These are what motivates suicide. One of the hardest questions people have to answer when it comes to suicide is we clearly are so deeply wired to avoid death, stay alive, avoid pain, avoid injury. How is it that these same humans who are wired that way, so to speak, biologically, arguably evolutionarily, will sometimes choose to take their lives? And I think the starting point for answering that question is to also understand that we are, in addition to that, we are deeply behavioral creatures. We are very much wired biologically, arguably evolutionarily, to do things that are paired with rewards, but avoid things that are paired with pain. This is evident even at a very early age. If a young child touches a hot stove and gets burned, they will very quickly learn not to do that again. So similarly, if someone's experience of being alive and engaging with life is that it is painful, it is miserable, it is aversive, then a powerful instinct kicks in that I don't want this anymore. Now, we of course are not only behavioral creatures, we also have thoughts. And so that's why hopelessness is also part of the slide and part of what I'm describing as the motivations for suicide. Because if we feel that our life circumstances can get better with time or with effort or with a certain sequence of events occurring, then our focus will be on achieving that better future. But alternatively, if our experience of being alive is that it is painful, miserable, aversive, and we then also become hopeless that things can get better, that is when we start to feel maybe being alive is not for me. Now, I am intentionally broad with my use of the term pain. Just like in very foundational behavioral experiments, when we ask the question, what kinds of punishment, so to speak, will encourage people to stop engaging or performing a certain behavior? The answer is anything that's aversive, electric shock, loud noise, social exclusion. That, of course, applies to the diversity of things that we might find painful in life. There's not going to be just one answer, because what brings about pain or misery or aversiveness is going to be different for different people, whether it's tied to relationship experiences, overwhelming financial struggles, various kinds of mental illness, experiences of systematic oppression or racism, and so on and so on and so on. Also, physical pain, chronic medical conditions also applies. Anything that makes life aversive is going to trigger this instinct that we don't want this anymore. And when that's paired with hopelessness that we don't have a way out, that's when we start to feel suicidal. And while I don't have time to go deeply into it, there are explicit data on motivations for suicide across 5 different populations at this point: adolescent and adult, inpatient community, where pain and hopelessness are overwhelmingly, by about 95% of people, endorsed as the important or most important motivations for suicide, as opposed to other possibilities like feeling like you're a burden on others, social isolation, cry for help, and things like that. Now, whereas pain creates that push away from life, connectedness is what is the pull toward life. So connectedness is what makes life worth living. And even for people experiencing pain and hopelessness, if you're able to maintain connections to life, then that the pain can even be worth it, even if we're hopeless that things will get better. Alternatively, if important things that you're connected to are being dwarfed by the sheer intensity of the pain, or the pain gets so severe, it sort of takes away our ability to engage with connections we otherwise would value or cherish, or in some cases, maybe we just don't have many connections, then it simply doesn't feel worth it to stick around with this intense pain and the hopelessness that things can get better. And I think it's important that we define connectedness broadly here. Certainly connectedness to family or loved ones or friends is often a very, very essential, important part of connectedness. But connectedness can also be to a valued role or a valued job, to a pet, to sometimes even to television shows that we look forward to. Connectedness comes in all sorts of forms. The commonality is that it gives us some sort of sense of purpose or meaning. So connectedness here is really connectedness to any sense of purpose or meaning. Even if someone's in pain and hopeless, if they're able to engage with these connections and their connectedness, so to speak, is exceeding their pain, they will stick around. They will be one of the majority of people with suicidal ideation, suicidal thoughts, where it tends to be kind of more modest or occasional. Less often is suicidal desire very, very strong and intense. And that occurs when the pain is exceeding or overwhelming or dwarfing the sense of connectedness. Now, if someone is struggling with pain and hopelessness, and that pain is exceeding or overwhelming their connectedness, from this perspective, they are someone who is desiring suicide. They are someone who's thinking, I think I would be better off dead, and I would choose that if I felt like it would work or I knew how to do it. And that is where this final factor comes into play: capability for suicide. Capability for suicide is what makes suicide feasible. This was a concept first put on the map by Thomas Joyner in his 2005 theory of suicide. And what he suggested is that even for people who feel suicidal, to actually attempt suicide is fearsome, is scary, and is difficult, because as I noted, we are deeply wired to fear and avoid death, and avoid pain, avoid injury. And so those are barriers to making a suicide attempt. What Dr. Joyner suggested is that we could acquire that capability over time if we sort of have experience with things that are painful, if we're have experience, let's say, with self-injury or with binging and purging or with traumatic abuse histories, things that have basically allowed us or forced us to habituate to things like pain and injury and self-inflicted violence. Those are examples of things that can increase capability. An important point is that there was a diversity of life experiences that could help someone or cause someone to acquire this capability to attempt suicide over time. And in more recent years, our understanding of this capability concept has expanded, probably most importantly to include practical contributors to capability. So one of the most obvious examples of this that I think has been on our collective radar for a long time now is access to lethal means, like access to a firearm or something along those lines would increase one's capability to attempt and die by suicide. But we're really expanding our understanding of what this means. So for example, if an adolescent who feels suicidal but can't imagine how to attempt goes on the internet, Googles, and learns that Tylenol is lethal in overdose, but not ibuprofen, then from this perspective, their capability to attempt and die by suicide has just gone up in a meaningful way. There's so many other examples of this. To give one other one, there's some data that anesthesiologists have higher suicide risk. And that causes some people to think, well, why are they feeling more suicidal? Or are they less happy than other medical professions? And I actually think what's happening here is it's not that they're more likely to feel more suicidal, but if an anesthesiologist happens to feel suicidal, their capability to act on those thoughts is substantially greater than other people because they're walking around with this exquisite knowledge about various kinds of drugs that can bring about death. They have exquisite access to those substances. And so that's just another example in a whole universe of examples of how practical circumstances have a lot to do with whether we're capable. So if we revisit these, if we understand the pain someone's experiencing, if we understand whether they're feeling hopeless, that there's a way out, then we understand what is pushing them away from life. If we understand their connections, and not just whether they're present, but whether they're able to actually feel connected to those things and appreciate those feelings. Because sometimes even if we have them, we lose that ability when our pain gets sufficiently intense. Then we understand what's keeping them alive despite the pain and hopelessness. And then finally, if we understand their capability for suicide, we understand the likelihood that someone with strong suicidal desire will act on that. And that gives us a complete picture of someone's suicide risk, at least at the moment when we're understanding those things. So let's talk a bit about how this information is actually useful. One way it's useful is it can help us organize everything we know about suicide risk. Just because I'm emphasizing these 4 factors, pain, hopelessness, connectedness, and capability, I'm not saying that everything else we've ever heard about doesn't matter. Of course, hundreds of other things matter. But what I am saying is that this model can help us understand why they matter, how they matter. So if we look at some various things that have been emphasized over the years clinically in the research literature, things like psychache, which was Schneimann's term for overwhelming psychological pain, things like depression, anxiety, emotional dysregulation, most mental disorders, general distress, all things that in the literature are correlates or predictors of suicide risk, they are probably making their primary contribution by increasing pain. If we look at things like the literature on the Beck hopelessness scale, some smaller literatures on pessimistic outlooks, external locus of control, learned helplessness, possibly self-efficacy, future orientation, things that have been linked to increased suicide risk, they're probably making their contribution through by increasing hopelessness, their primary contribution. These things can, of course, inform each other in multiple ways. If we think about things like social isolation, loneliness, poor social support, low belongingness, feeling like you're a burden on others, these probably make their contributions primarily through connectedness. And if we think about things like Thomas Joyner's acquired capability construct, access to lethal means, knowledge of lethal means, even some dispositional contributors to capability, like lower harm avoidance temperament or lower squeamishness about blood. These are the kinds of things that can increase capability to attempt suicide. And there are, of course, hundreds, thousands of things that are not on this list, but that could be. It's also important to just at least acknowledge that, of course, these things can and do influence each other. You know, if you're in pain for a long enough amount of time, you might start to feel hopeless that things can get better. If a valued source of connection is disrupted, a relationship ends, that could be a very painful experience and might even make it hard to feel hopeful about what's my future going to look like now. So of course, these things can and do influence each other. But what's very useful, I think, about this overarching framework is that regardless of what people are experiencing, it helps us understand how and why those things matter. All right, so revisiting our conditions for suicide, they can tell us some other things too, both what we can do, but also what we can't do. And I think one of the biggest mistakes we make in suicide risk assessment is that we think that if we just understand things correctly, if we just do things right, then we'll be able to predict the future. And this is simply not accurate. One of the implications of this framework is that we cannot accurately predict the future, because even if we understand very well at this moment someone's pain, hopelessness, connection, and capability, these things all have an ebb and a flow. We don't know whose pain and hopelessness will abate over the next few days or weeks or even hours based on time or circumstances. We don't know whose sources of connection could be abruptly harmed or severed or improved over even short time frames. And as I already gave some examples, even capability for suicide can change over short time intervals. And so we can understand suicide risk very well. This model could be 100% accurate, but it still will not allow us to predict the future. And it's essential we understand that. What's strange about this is this can feel alarming in the suicide risk world, but it is simply a fact in basically every other area of science and health. If you look at heart disease or stroke or cancer, even if you look at other causes of death like drunk driving or homicides, they all have situations where they are terrible at predicting who's going to next drive drunk. You can predict it by chance, but not much more than that, which is where we are in the suicide world. Tons of studies that whether we're talking about clinical risk tools, assessing suicide risk, clinical judgment, research studies, our prediction is above chance, but not much else. That is true everywhere else we look to. And it's one of the things that we in the field of suicidology need to start just embracing and accepting. Now, what can this information do? It doesn't mean the information is useless. In fact, every other example I just gave, homicide, drunk driving, heart attack, stroke, we have made huge improvements in reducing mortality and morbidity in recent decades by using our knowledge of the conditions that cause those things and wrapping prevention around those conditions, even though we can't predict. So what can these conditions tell us if we accept them? They can do a couple things for us. First of all, they do give us a very important snapshot of someone's suicide risk in a given moment. So if you have someone where people are at peaks of pain and hopelessness, and they're just not feeling their connections, and their capability for suicide is present, then you have someone who in that moment is at very high risk for suicide and possibly in crisis. And that's a sign that we need to intervene. These also can help us give broad categorizations of suicide risk. And if you think of some of those other domains I mentioned, like heart attacks or heart disease as one example, this is actually how we operate. No one expects a clinician or a doctor if someone died by a heart attack a week after having an appointment with the doctor, no one tells the doctor, how did you not know that was going to happen? You measured their blood pressure and their cholesterol and took all these other measurements. No one expects that because it is unrealistic in any field of health. But what we do expect is some broad categorization. Okay, your blood pressure is higher, given your age, given these other factors, you're broadly at high risk. And then we wrap prevention around that. Sometimes it could be lifestyle change. Sometimes it could be targeted medications towards blood pressure, cholesterol. It also involves psychoeducation. Here are the warning signs of what a heart attack feels like and how to respond if you notice that. As far as we can tell, that's had a huge impact on improving help-seeking behavior. We can use this information similarly in suicide risk. If someone's broadly at risk for these kinds of things being higher, based on circumstances, based on mental illness, based on medical conditions, based on relationship status, and so on and so forth, we can explain these are things that broadly increase your risk. We can have safety plans that target these kinds of things. We can also know to monitor these kinds of things, to be on the lookout for them. If we have a client who says, the other day I was feeling existential, I wasn't feeling suicidal, maybe thinking about it a little bit, and I kind of walked to this high bridge near my house. And I kind of looked over the edge, thought about life, and walked home. Now, some of us would say, all right, we got to do our suicide risk assessment here, and that's probably true. But in this example, the person will honestly tell you I wasn't that suicidal and I wasn't planning on doing it. But from this perspective, we have to realize that the person did just increase their capability for suicide. It is now more in their behavioral repertoire to walk to that bridge, and perhaps they even habituated a little bit to what it's like to be looking over the edge. And so maybe what we might do in this hypothetical is revise or add to the safety plan. If you've noticed yourself experiencing overwhelming pain and hopelessness, if you notice yourself feeling suicidal and going to that bridge or thinking about going to the bridge, let's have some options in your safety plan for alternative actions you can take, and we can titrate that safety plan a little bit more. A final point I want to make is in terms of intervention or prevention, is that these are the targets. Regardless of the kind of intervention or prevention method that we are using, what this perspective implies is that any prevention effort for suicide risk will succeed to the extent that it can impact one or more of these targets, to the extent that it can reduce pain and or reduce hopelessness, like I said, reduce pain, reduce hopelessness, and or enhance connection, and or reduce capability for suicide. And what's so important about these points of intervention is that we can do them in so many ways. We can certainly target these as part of our individual therapy or counseling. We can even think about some of these as targets for medication. If an antidepressant or an anxiety medication reduces depression or anxiety, that will reduce pain. That should impact suicide risk. Our safety plans can help protect against capability, but we can do this in many other levels of intervention too. Our crisis lines, in addition to everything else they already do, can be thinking explicitly, what can I do to ease this person's pain in the moment? What can I do to increase their hope? What can I do to give them a sense of connection? And what can I do to make sure that, to maybe lower their capability? This can happen in emergency rooms at hospitals. This can even happen on 911 emergency phone calls. We can intervene at the level of communities, including schools, and including in some Indigenous communities with very high suicide rates. And notice how the kinds of interventions we would do to impact pain, hopelessness, connection, and capability would be very different in some communities compared to others, and can very much happen in collaboration with those community members and leaders. There are even ways where we can do this at the level of population and government to impact the kinds of things that systematically impact pain, hopelessness, connection, and in some cases, even capability. All right. I have no idea if I've been given warnings because there's 34 chat messages, but I'm pretty sure I'm right at my 20-minute timer mark. So with that, I will pause. I understand we're taking questions after all the talks, and I will turn it over to Dr. Crawford.
Thank you so much, Dr. Klonsky. Really appreciate your work. I feel like if we could do all of those things, we could all pack up all 900 plus of us and go home. To really thank you. And I think there'll be some continuity here, hopefully. I'm going to pull up my slides. Okay. I thought I would start with this drawing by Shuvani Ashuna, which you can see part of. And Shuvani is an artist in Kingite Nunavut, and I had the great privilege of talking with her about this work, and she described it as worlds within worlds within worlds, amongst many other things, and what it's like to simultaneously experience, being across worlds within worlds. And so, I'm going to talk a little bit about cultural safety today and the context around suicide risk assessment. And I think this is a helpful positioning and reminder for us not only to think about the worlds of the people we interact with, and I use worlds with an S on purpose because, intersectionality is another way of saying that. Most of us occupy lots of different social positions. And maybe point number one and the main foundational point is we also, as whether we're clinicians, policymakers, researchers, have our own positioning that we have to be very well aware of when we engage with others. So I'll tell you a bit about myself. I am first generation Canadian. My parents are Irish and Scottish. I'm non-Indigenous. I'm the mom of two awesome Inuk kids, and have worked in Nunavut and in other circumpolar contexts, and feel very connected to some specific communities there. And that really ties me to and grounds me in this work. Nothing to really disclose here other than to say many times over that this work is always a very collaborative effort. In particular, some of the slides are shared with Rennie Linklater, who I work with around cultural safety. And I'm going to be sharing some work from a group called Project Creates, a project called Project Creates, and many team members there as well. And what I want to share is really more of an ongoing conversation that, rather than a set of facts. But as we learn more and more about suicide risk and protective factors, and things that are relevant to our clinical practice and other areas of work, how does what we know fit in across different contexts, particularly equity-seeking communities, or communities that may not have the same access to services, or who may have different ideas about how they want to approach questions of living and suicide prevention. And at the end, I'll talk about cultural safety. That's a much more widely understood and discussed concept, so I won't spend too much time on it, but I'll define that towards the end and think about cultural safety and suicide risk assessment. And I thought I would briefly put this up as a kind of contrast. So this model by Houghton and colleagues, very useful in bringing together a lot of research-based understandings of suicide. And to my mind, I think it's very beneficial to change the dialogue away from so right around the time that people contemplate or engage in suicide behavior, and take a more longitudinal perspective. But one of the things that strikes me about this, working across different communities, is the real emphasis on the individual, on individual risk over time, and very little emphasis on, you see it in the corner, bottom left corner, on the social context and life circumstances of people and groups, and the way that those social determinants have also impacted suicide risk and protective factors around suicide. Similarly, things like, I think a lot of us as clinicians, I kind of straddle both worlds. You know, we feel a lot of pressure. We can see in our electronic health records, we have to rate whether people are at low, medium, or high risk in our institution, which comes back to this kind of approach, familiar to many of you, the SAD person's approach, which is sort of checklist. You know, which risk factors does this person have? And presumably, if we can add them up, we can say whether the person is at low, medium, or high risk. And this really ties into what Dr. Klonsky was saying. But what happens when we take that knowledge and apply it to unique contexts? And I'm going to spend, I thought I would talk more specifically, because I think that's also very important to cultural safety, that we understand the specificity and uniqueness of different contexts, and understand individuals as existing within that in multiple contexts. So what you see here is a graph of rates of suicide, death by suicide in Inuit Nunangat, the 4 Inuit regions in Canada. And you can see, yes, that the rates are quite elevated within those regions, but there's also a lot of difference between regions. And so understanding what has led to those rates, I think if we confine ourselves to something like the SAD person's checklist, obviously we are going to miss an enormous amount of context that's important. And one of the big factors or understandings that's necessary is thinking, so in that Houghton model we see risk over time in the individual, but much more important here is the risk over a longer period of time, the historical context and the way that that historical context has carried into the present and been perpetuated. So from colonization and then all of the effects that flow from that, from communities into families and into the individual, and how that impacts the way that people present in the moment, and also how it should shape it. This is changing. It hasn't always shaped the kinds of prevention efforts and intervention efforts that we have, and thinking about collaboratively participating in supporting resilience and strength, and strengths rather than just taking note of the risks in particular individuals. And other researchers who've looked at this, and so Lawrence Kiermaier and his group in this model look at community and social factors in addition to in how they might line up with individual or psychological risk factors. And the work of Chandler and Lalonde, which, while there might be different factors that are important in different communities, really drew attention to the strengths that come from cultural continuity, including things in their sample like self-government, having land claims that have been litigated, and having local control over institutions, including healthcare. And this is the work, this is from the National Inuit Suicide Prevention Strategy, which I had the great fortune of participating on through ITK's leadership. And that's really outlined here, thinking about risk factors, not just at an individual level when people, so you see at the bottom where people experience acute stress and loss, but all the way up to the historical context of loss and community distress and distress within the family. And equally, to think about protective factors and understanding the strengths within communities so that those can be supported and drawn forth and understood so that they can be also supported through programs. And most importantly, I know we're talking about clinical assessment today, but I think it's impossible to just think about clinical assessment, and that we all have to find our place in roles in supporting people in their socioeconomic circumstances and advocating for really the impact of social and environmental and economic risks and protective factors for individuals and communities. I'll tell you a little bit about work at the Arctic Council level where I have really seen this shift. So starting in about 2015, the Arctic Council has really been interested in suicide prevention. This is a paper where when the US was chairing the council, where a group of scientists really looked at how do we think about outcomes? How do we think about those risk factors and researching those more, growing an evidence base at the community level. And you can see some of those things in this paper. One of the things that really, actually it did start within that work, but everyone recognized there needed to be more attention to actually involving the people that we were talking about, the youth who were most impacted by these circumstances. And so during the subsequent chairmanships over the last number of years, we launched this project called Project Creates. Create stands for, I'm going to test myself, Circumpolar Resilience, Engagement, and Action Through Story. So engaging youth initially through digital storytelling to understand what they felt was important to know about their strengths, their worries, their hope, their hopelessness. I was really thinking very much about Dr. Klonsky's framework might apply here, but hearing from them. And I'm going to share a story with you from one of the youth. This is shared with both consent and ongoing permission it's a story by Byron Nikolai, who is from Alaska, from Tuksuk, Alaska. And while you're watching it, what I would invite you to think about is what are the implications in what Byron is trying to say for understanding suicide strengths, so strengths and also risk factors. And we determined earlier that it's better if I actually come right out of this and reshare. Okay, it's fairly brief, just a couple of minutes.
Alaskan pride, Alaskan grown. Young buck mate moves on my own. Did it for the people back home and more. Kept going and going, using no back door. In the middle of I got it, but a young one wants more. That I tell and the stories that were told, they're the key to my identity. It's worth more than gold, and the knowledge passed down is the reason we survive. From the UP keep the well and alive.
Okay, just get out of there and go back into my slides. Okay, and I mean, feel free to put any observations in the chat, but hoping that you notice things like, you know, his connection. He's making this connection with this archival footage that he found of a connection he feels to ancestors and elders. The land is featured very much, and the connection to that. His identity, you know, through his rap song, he talks about many of those features, and many more things. And I won't talk too much. I'm talking about the themes that these youth wanted to communicate. And we also travel with youth and have them present their own stories usually. But also there were lots of positive impacts, I think, if I think of that three-factor model around connection. So youth feeling an affiliation with each other across the Arctic and feeling like they were making a difference. And many of them are still involved a number of years in a network. Oops. And here, this is a brief summary of the themes, and many of the things I've talked about really came out in that analysis. The focus, you'll see people, youth really wanted to see a focus on the community more than anything when they thought about suicide prevention. And rather humbling, if you look down up, not as many wanted to focus on the clinical setting. And all of the themes really that I spoke about came out in these stories. So I'll end with just a brief note about what does this mean, clinically or in our approach to suicide prevention. And this photograph of a sculpture by James Ciolak, also from Kingite, I love it because it really reminds me that culture is not ancient or ancestral thing. It's a living process, and we're all part of cultures that are growing all the time. And so, the old cultural competence model where you could become competent in understanding a particular culture is very limited. Cultural safety, on the other hand, is about the stance that we take, the way of thinking about culture in all of our interactions, in particular within healthcare. And that concept originated in New Zealand amongst the Maori. This definition is from Sanyas. If you haven't taken the Sanyas course, highly recommend it, an online course on cultural safety. And it's really about setting a context defined by the other person, defined by the person who is receiving care, where there's shared trust, shared respect, and respect for identity, and recognizing people's cultural locations and their values and their preferences, and recognizing different knowledges. And for us as clinicians, no matter where we come from, just a prerequisite stance of cultural humility, knowing where we come from, knowing our own place and our own biases, and bringing that with us and continually fostering that through processes of reflection. I won't go into this, but very important to also acknowledge that this includes valuing and making space for Indigenous knowledges and approaches, and to think about the way that we currently assess risk and protective factors. And I thought I would briefly mention, this is almost hot off the presses by James Allen and colleagues, work done in Alaska on the Reasons for Life scale. And they found an association between some of these cultural strengths, cultural identity and values, and protective factors around suicidal thinking, suicide-related thinking. And what does this mean? I'm going to end here. What does this mean for our work? Here are a few principles that I've hopefully alluded to. So having that stance of cultural humility, of always learning, of being open, assuming strengths. So we do all get very preoccupied with assessing risk, and understandable when you're alone in a consulting room with someone or in a clinic or on a crisis line, but also remembering the strengths. Being trauma informed, I didn't have an opportunity to really talk much about that today, but there's some alignment between cultural safety and trauma informed care. Taking a perspective of holism and thinking about the person's whole life context, including their social situations, circumstances, and strengths. Evaluating cultural safety, which really means asking the person who's received care, not whether we think the service is culturally safe. It's easy to take a module and say, check. Knowing resources that might be more meaningful to people. Partnership, sharing knowledge, sharing design of programs, etc., and sharing research, and Indigenous leadership being at the forefront of this work. And here are just a couple of resources: the Wise Practices for Life Promotion website, and also the Hope for Wellness helpline. All right, and Dr. Sadek, I am going to pass things over to you now.
Thank you very much. Thank you very much, Dr. Crawford. I hope you could hear me okay.
We can, Dr. Sadek.
Thank you. I am gonna share my screen, and I'm actually delighted and honored to be here. I also found both presentations from Dr. Klonsky and Dr. Crawford has been very helpful and I am also delighted that this would bring some of the discussion to light here. So I want to go through the Nova Scotia experience of what we did in terms of suicide risk assessment and management. And I am going to try to be brief. This is the last section. So we all understand fully why suicide prevention is so important. This is not a small topic by any means. This is quite serious. The impact of each single suicide is immeasurable. Huge impact on everyone. We all have had this impact in our lives, and this is something we all need to work on to prevent suicide. On average, a single suicide affects at least 6 people, and of course it's way more, and particularly if it happens in school or workplace, hundreds and hundreds of people. And the burden of suicide that is actually can be measured is twice the burden of diabetes. It has quite significance in many areas. Epidemiologically, we had 4,000 in 2019, 4,012 people died by suicide, and rates for men were about 3 times the rates for females. And we know that the age group between 40 to 59 has the highest rates. And we also know that rates, as Dr. Crawford mentioned, is about 11 times the national average in Indigenous youth. You can see that the middle part is the highest suicide, as you can see. We wanted to meet Accreditation Canada standards. We wanted to review the current literature, and we also wanted to review the morbidity and mortality cases. So we wanted to look at all the cases that, we had morbidities or died, and we want to learn from what happened. And we wanted to identify some of the challenges in current structure. So the difficulty is there's no scale that can really accurately predict, as Dr. Klonsky mentioned, predict identify who's going to die by suicide. And we didn't think it's possible to design such a tool. But what we hope to do is to develop a tool that help the clinical judgment of every clinician trying to assess suicide risk. So we are not going to give you a tool to tell you this is how you are going to predict the risk. No, we are just going to make sure you make a good clinical judgment based on informed decisions. We are going to lay all the factors for you. So when you make a clinical judgment, would be a more informed clinical judgment. And Accreditation Canada, as you know, says that everyone at risk of suicide should be identified. The risk of suicide should be assessed at regular intervals or as need changes. Treatment and monitoring strategies are identified. Implementation of treatment and monitoring strategies documented in the client record. We started looking at the challenges, and the challenges in suicide risk assessment are numerous. One of the major challenges has been the subjective information that sometimes we get does not give you the full picture of the risk. So someone would say, well, I have no, I have no suicidal thoughts. And then collateral information tell you that there is. And we incorporated in our new tool a space to make sure that we get collateral information when possible to assess the suicide risk. We also relied on clinical judgment to basically allow for the relevant information to make a sound judgment. Because again, using any scale do not accurately predict death by suicide. And I was just reviewing this year numerous criticism of some of the scales that's currently being used, and a mounting amount of criticism, particularly type 1 or type 2 errors. And so what we are just simply hoping to achieve is a sound judgment. There was one of the challenges we identified is the lack of consistency in education and training of healthcare providers in the simple competencies needed to do the suicide risk assessment. And so we thought that having a full training program that for everyone would be helpful, including video modules, a book, an ebook, case studies, and face-to-face training. So we developed Train the Trainer program, and to simply strengthen everyone's ability to make this good clinical judgment. One of the other challenges is that sometimes suicidal behavior can produce intense emotional response from clinicians. So I could be assessing suicide risk, and then I am not recognizing how much this is affecting me. And we started bringing this reaction to the surface, started allowing for extra training, extra mentoring when you have this type of reaction, so you could, the assessor would manage their own reactions as well. One of the bigger challenges, one of the other challenges is that sometimes the suicide risk is not documented and is not communicated to others. So there are 3 people, for example, a psychiatrist, a psychologist, a social worker, working with the patient or the client, and this risk is not communicated between the, 2 of them or among the 3 of them. And so our tool basically allowed for this type of communicating the risk among providers, of course, with a consent. And it's a 1-page, so it would allow also for documentation to have it, so you can actually go 6 months later and look at how it changed from that point. One of the important issues that we were faced with was the chronic risk versus acute risk. So someone who wants to die today versus a self-harm that is happening with no intention of death. And we really designed modules to discuss the difference. And unfortunately, 7% or more of patients who self-harm might end up dying with suicide. So we started looking at what disorder would have a higher risk of self-harm. And we started, for example, identifying these. We started discussing the symptoms of borderline personality disorder, the 9 symptoms, the fear of abandonment, the mood swings, the difficulty keeping relationships, impulsive behavior, anger issues, identity problems, and sometimes dissociative or paranoid symptoms and the feelings of emptiness. And we started linking that to what happens in a person's life. And that has also been very helpful to understand both the chronic risk and the acute risk. And one of the challenges is that people told us, well, you can't really prevent suicide. This is not the responsibility of the mental health. And the research tells us that majority of patients who died by suicide, they had a mental disorder pre-existing. So mood disorder, like depression, substance use disorder, were found in about 2/3 of patients who died by suicide, and some personality disorders. And we can't ignore the social dimensions. And that's what Dr. Crawford focused on today, because that's also another huge factor here that we can't ignore. So the question would be, would there any examples that suicide was prevented? Yes. I am here to bring you some good news. We know that in Japan, for example, there is, in Akita University, a 50% reduction in suicide in a town in 4 years. This was completely a social intervention. We know in UK, in inpatients, after improvement in service delivery, they achieved 20% reduction in completed suicides in service users in 2 years. Now, the model in Nuremberg, Deutschland, in Germany, after 2 years, this program resulted in 24% reduction in suicide and suicide attempts. And I really enjoy talking about this program because I think it's very easy to do here, and I think it's useful to look at the 4 areas that they did. So they, this is University Akita International University in Japan. Of course, you know, your UK, and that's where in Germany that program took place. They focused on 4 areas. Number 1, the primary care providers. Number 2, they focused on decreasing stigma of mental health. And then they started connecting with community gatekeepers. So the teachers in schools, the social workers, religious leaders, and families of patients who are struggling with mental health issues. And I think those, you know, this connection has been very, very useful and important. So this idea about community gatekeeping, I am very much advocating for that. And then they developed the target interventions for people who are having suicidal thoughts or have attempted before. So this program can be replicated quite well, and I think it's a useful program to also consider these helpful areas: primary care, decreasing stigma, community gatekeeper interaction and teaching about suicide, particularly for teachers, social workers, you know, religious leaders, and families, and the targeted intervention. So this program resulted in a significant decrease in 2 years in numbers of patients who died by suicide. The other important issue that I want to emphasize today, and that's more for clinicians and for my colleagues, is that there is some evidence that thorough assessment after self-harm may improve outcome. And that's actually, if you look at the Dr. Klonsky's model, you would see the idea about connection. And that's what I am trying to say here, is that an assessment with a clinician who is connecting with the person could be therapeutic on its own. As a matter of fact, in our training, we emphasize the concept of therapeutic alliance. What is therapeutic alliance? Therapeutic alliance means empathy, active listening, respect, trust, support, non-adversarial stance, non-judgmental, strong interest in understanding people and their difficulties. And that is important. We were faced with people asking, if I ask about suicide, would that make the patient more likely to act on it? No, absolutely not. It's a matter, it's actually a false perception. It's a barrier to assessment, the beliefs held by some people that asking about suicide would induce such thoughts in patients. Our training included a policy of what to do, and that also, not just for all the clinicians, we also started looking at support staff. So for example, a recreation therapist who goes out with someone and then they say, I want to kill myself. What's going to happen? So We give introduction to the suicide literature. We had modules on suicide, self-harm, other disorders. We started, talking about the core competencies, such as therapeutic alliance that I just mentioned, which again involves active listening, empathy, respect, support, non-adversarial relationship, non-judgmental, strong interest in understanding people. We wanted to identify the risk factors, collecting collateral history, formulating the risk, and then managing the risk, documenting and communicating the risk with a future quality monitoring. This is a very simple one page that we use, and we just basically, within the interview risk profile, we talk about those risk factors, what's happening in terms of patient's current illness management. Is their clinician is away on vacation? Is there is not taking the medication or not responding to treatment? Is there other risk factors? And Dr. Klonsky mentioned the chronic medical illness, the pain. And as you can see, the pain is right included here. We also mentioned the circle of support. So family, lack of the family, lack of support. This area about connections that Dr. Klonsky mentioned as well. Caregivers unavailable. We really didn't put any emphasis on the buffers. We have a communication plan to say, well, this was communicated to these people, to the families, to physician, to a nurse, to others. The documentation was put in the patient chart. And then a very simple, what are we going to do next? And some information. And it makes me able to make a better judgment and informed decision. So that's really what, you have the risk, and you have some of the individual risk profile, like the cultural risk groups, and that's what Dr. Crawford mentioned many times. And as you can see, it's right on the top here. And then the other risk factors, and you would have, feel free to have a copy. And so those were our direction, because we wanted something to do now, today, at that time. Now, what should we do in the future? We want to think about the model that return of investment in human capital. So the earlier the age of you start the investment, the higher the return. And we want to start thinking, considering the trend towards a progressively younger average age when suicidal behavior occurs. So this Heckman proposal seems very important. So if I start early here, I would have a much higher return on investment. And that's what we need to start thinking, which I want to move it to a primary prevention rather than a tertiary prevention. And that's where I want to say, okay, what can we do today in our communities to have the healthy, growing kids so we can avoid these difficulties later on and not move in that direction. So I want to leave you with these words to remember that if patients have mental disorder, perhaps they might later recover, change their mind, and many people are relieved to have survived suicide. And we usually conclude to give the patient the benefits of the doubt, and that whatever we do should assist in preserving of life, not the opposite. This is published in The Lancet, and I think it's a very valuable statement that I want to end here. Thank you very much for listening. Now I am going to move it to Nikita. Thank you.
Thank you so much, Dr. Sadek, Dr. Klonsky, and Dr. Crawford. I cannot tell you how much your presentations have sparked a conversation that's been happening on the side chat this whole time about people sharing their stories, people sharing their experiences. I've been deeply touched to see some of these stories being shared today. Some of them that I would like to kind of even bring to your attention, a little bit about the video that you shared, Dr. Crawford. It's been, the words that have been used are so powerful, brought tears to my eyes, seeing this, their pride, feeling the weight of my and my ancestors' role in colonization, and feeling that the video really showcases empowerment, which is a great protective factor and great project. So I wanted to share that. I did also want to share just the enthusiasm with which the 4 conditions that you presented, Dr. Klonsky, and how they were just positioned in the way that it could be understood or is being shared, as well as sort of the experiences that you just shared, Dr. Sadek, and has sparked a lot of questions and comments and interest around just the process of suicide risk assessment and really how diversity plays a role into that. So I would love to go right into question and answers, and I know we won't be able to get to all. So for all those who are listening, we will be making sure that we do get the rest of the questions answered as well, and bring them to you. I'm going to start with yourself, Dr. Klonsky. When you presented, you mentioned pain being one of the conditions. So one question that came to us was, would physical pain make sense here too? Your thoughts on that?
Yep, absolutely. Anything that makes life aversive, miserable, painful, including physical pain, including chronic medical conditions that are painful and difficult. And I know, I think Dr. Sadek alluded to that as well.
Thank you. And just a little bit deeper into the 4 conditions. So the question that came was, if someone is set on suicide and all 4 conditions are present, then why do other people offer help like suicide hotline numbers? The person has already decided, so why would they want someone to change their mind? I just want to see if you had any comments to share, or maybe others as well.
Yeah, I mean, I think I also gave a written response to that answer to that question in the chat. It's an incredibly difficult and important question, and it gets very quickly into fundamental questions about autonomy. Who are we to tell someone else how they should, live their life or end their life? One answer I have to that question is actually, Dr. Sadek alluded to it, I think towards the end, that when we look at studies that track people who attempted suicide using means that usually end in death, more than 90% do not go on to die by suicide. Many explain very explicitly how relieved they were that they did not die. Some say that the moment, and I'm thinking of a study about people who jumped from the Golden Gate Bridge and survived. Some say that the moment they jumped, they immediately regretted it and wanted to take it back. And so because the vast majority of these people do not go on to die by suicide, and also based on the reports, we have one way to look at that is that people's own future selves are glad that they stayed alive, and that their own future selves are much more likely than not to choose to stay alive. And so that's a powerful reason to keep someone alive. At the same time, I'm not going to pretend that that's a fully satisfying answer. There are some people who have chosen to take their life, and their future self might make the same choice. And by trying to save them, we are interrupting their autonomy. And it is above my expertise and pay grade to say, how do we weigh that philosophically, morally, ethically? Can we choose to force someone to stay alive when they don't want to? It's a very hard question. The last thing I would say on that is death is more final than keeping someone alive. So I think there's a way in which, because the vast majority of people who are kept alive are grateful that they were kept alive, and because there's a greater cost to being wrong in one direction than the other, I understand why it's best practice to keep people alive when we can, but that doesn't negate the importance or difficulty of that question. And I do see someone in the chat referencing Kevin Hines, who is the person I was describing, who said explicitly the moment he jumped, he regretted it.
Thank you for that. And the role of crisis lines, and maybe Dr. Crawford, I can pose this question for you. There's been so much discussion in the chat around the role of crisis lines and Some people have had a good experience. Some people are talking a little bit about the assist training and the benefit of having that training provided to responders. Then others have talked a little bit about the experiences that have not actually been helpful, or that someone has had to call 8 times on behalf of their brother because they've been experiencing suicidal ideation, and they lost their spouse to suicide just recently as well. Again, so much sort of wide array of discussion around crisis lines and the role that they play. So just wanted to pose that question and have your comments on that.
Absolutely, and I appreciate your ability to bring all those threads together, because I saw those similar things. And I think there's continuity between the question for Dr. Klonsky and this question. So many of the things that we do constitute known risk factors, like depression, hopelessness, psychotic thinking, substance intoxication, are transient in and of themselves. So if you give people the chance, and I think crisis lines are one way of giving people a chance during those moments of crisis that hopefully will help get them through so that they can reevaluate. You know, we all believe in autonomy, so people can reevaluate. And crisis lines also provide for many people a point of connection when they may have other limited connections. So I think that there are many reasons to value them. They're also very community-based usually, so it gets people in the community very actively involved in a really important issue. And I know at the Canada Suicide Prevention Service, we're trying to, even though it's a national service, we're trying to preserve that community engagement. There is evidence for crisis lines. Unfortunately, because of the nature of crisis lines trying to do that work, it's not long-term evidence for the most part. There are a few exceptions to that in other countries, but there is evidence that they reduce distress more often than not, and that helps with all of those things that I mentioned. What I was going to say, one last thing. Oh, I think there are challenges to the crisis line setting. It's not very well connected to other aspects of healthcare, and there's work going on in Holland, in the U.S., trying to better connect crisis services to make sure people can flow in and flow out of crisis services to be part of more of a systems-based net rather than just stand alone. So those are a few initial responses.
Thank you for that. Another question that I'd like to pose to you, Dr. Crawford, is around this question around what may be other reasons behind such as collectiveness, identifying oneself with their negative past that's gone. What is the reason that it's still sort of uncured, that there's still that feeling? Can you comment a little bit about that?
Yeah, I saw those comments, and appreciate that kind of discussion. I think my most immediate response is, like, the past is never past. It's not just about, history has a way of impacting us in the present in a number of ways, through our own changes to our own genetic expression of our genetic code, like epigenetics, parenting and family environment, and also just grief, the carrying exposure to suicide. So I think there are many ways: socioeconomic adversity caused by colonization that persists into the present, racism that persists into the present, reminders of when healthcare was, or times that it has been racist and harmful. And so then you're turning to those resources for help. So I think there's so many ways that that history impacts the present. I do also think that there's room to, once you're in a trusting relationship with someone, so this would be more therapeutic, to challenge, broaden, think about people's narratives so that they see the strengths of their history as well as some of the challenges, if a particular individual is really pained by that. But I think more important is to understand the collective impact of historical events in the present. Yeah.
Thank you so much. Dr. Sadek, I had a few questions there for you as well, and I wondered if you can comment a little bit about the the suicide, there's another sort of suicide risk that someone factored in that's not often addressed and that goes unnoticed, they feel, and they're calling it the passive suicide. Some people never make an attempt, or don't want to, or have fear or stigma associated with it, or never even self-harm, or have no easily visible signs of distress. But they often just sort of stop living or doing whatever is needed to not to continue to live, in the hopes to sort of die quietly and by natural means. What would you say to that, and the work that you've done in Nova Scotia? How would you respond to something like that?
So I think that's a difficult situation. That is an area where possibly the individual is struggling with depressive symptoms, and this depression has been untreated and has been going on for a long time. And probably with that, there can be a lot of other stressors. And when we actually could imagine that once this individual loses, for example, support, or more stressors come to their life, things can, reach a degree of wanting to end your life actively. And that brings me to the idea of the importance of the social circle and the family support to actually bring these issues to life and bring the person to care. And so I am here advocating for families to be more supportive of each other, to be more, looking after your loved ones. I am advocating for more family interactions. I am advocating for more social interactions. I am advocating for more social support. I think this is not luxury for humans. Those are very important issues.
Thank you for sharing that. Another question that I wanted to pose for you is, does the risk formulation change when assessing someone for more suicidal behavior during the first sort of 48 hours after surviving suicidal behavior or attempt?
The risk assessment is a very dynamic process, and it changes, frequently. And so the fact that right now the risk level is high, it doesn't mean that, tomorrow is going to be high. It's a dynamic, continuous process that needs to be looked at as it happens. So
thank you. Dr. Crawford, there was a question that I would like to ask you as well. Someone who's attending the webinar today said, I work with many queer and trans and BIPOC folks. Many are understandably afraid of police being called. This person specifically is calling from Vancouver. What work needs to be done to help folks to stay safe who are in imminent risk of suicide? And they want to hear your reflections around that. Your thoughts?
Thanks so much. First, I think that cultural safety, it has its roots in Indigenous health and in Indigenous ways of knowing. So I think it's important to respect that. At the same time, I think that cultural humility is important and can apply so broadly. And I think having the same approach as responders, as clinicians, researchers, to other communities that we may not fully understand, and also making space for leadership from within those communities. I think it is obviously an important risk factor that hopefully can also be turned into a strength. But we know that many, especially transitional age youth who are exploring their gender, their identity, also have some elevated risk. And so the more we can figure out the right protective factors and involve people from those communities, I think the better. In the meantime, I think having that cultural humility and just making services available ideally, by community, like for community, but when not, having, just general services have training and to be available.
Mm-hmm. I'm going to pose maybe one or two last questions, but I will share with you that there are so many by the attendees that we'll certainly be capturing those and reaching back out for your responses. And our colleague at the Commission, Megan Bernstein, will be able to capture and facilitate answering those questions. But maybe I can pose one question to all of you. Is any comments that you have about assisted dying for individuals who experience severe and treatment-resistant resistant bipolar disorder? So just your comments around assisted dying.
Who's going first? Okay, for me, I do think this is an area where it's very important to explore and reflect on your own personal beliefs, because I think this is kind of a changing belief system in our time, a changing social belief system in our time. I'm personally concerned about the lack of constraints or evidence for people with mental illness and MAID. I personally also believe that MAID should exist, but I think that we just don't know enough, and it feels to me like we're rushing in. And the question for me revolves around what's called irremediability. So the belief, when do you arrive at a point where you don't think that the mental distress or mental illness is treatable? And we don't have an evidence-based way to answer that. So we're left with this burning social question, moral question, without evidence. So I just think that more engagement and more research is necessary. That's my personal opinion.
Thank you. I just want to acknowledge that we are at 3:30 Eastern. So I just want to thank you all, Dr. Klonsky, Dr. Crawford, and Dr. Sadek, for your presentations. We do want to remind everyone, again, please do keep sending your questions and we will make sure we get the answers to you. The presentation itself and the recording, it will be available on our website in English and in French, as well as just, at the end of this presentation, I do hope that you will take some time to answer to our polling questions, as well as just give us a little bit more feedback. So the questions that we're asking today is, please rate your knowledge about today's topic, as well as rate your knowledge, your own knowledge about today's topic after the presentation and before. And please indicate your agreement with these statements that are listed in there, that you learned something new, that you learned something that you can apply to your own suicide prevention work, and that the presentation was effective or not for you. I really want to thank you all again for joining us today for such a vibrant conversation, and all the speakers and panelists for your time today. Thank you, everyone, and have a wonderful day ahead.